Welcome to the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. In this episode, we discuss epilepsy. Our goal is always to inform and start conversation.
So epilepsy is a neurological disorder where the brain activity becomes abnormal. And this causes seizures or periods of unusual behavior, sensations, and even sometimes loss of awareness. There are many different types of epilepsy and several different types of seizures that epileptic patients can have. And we're going to kind of break those down a little bit later on in the episode. There are several different causes of epilepsy. It can be genetic from head trauma or traumatic brain injury, conditions that cause brain damage to the brain like a stroke or a tumor, infectious diseases like meningitis or AIDS, and then prenatal injury or developmental disorders like autism or neurofibromatosis. Those can all cause epilepsy.
So you probably know already how much we love our statistics.
They know what's next.
So here are a few, and these are for the United States only, but studies have shown that other developed countries have very similar numbers. Epilepsy is the fourth most common neurological disorder and affects people of all ages. About 1 in 100 people in the United States has a single unprovoked seizure or has been diagnosed with epilepsy. 1 in 26 people will develop epilepsy in their lifetime, and roughly 0.6% of children aged 0 to 17 years have active epilepsy.
That's tough.
That's
the
a
school
lot
age
of
kids, yeah.
About 3.4 million people with epilepsy nationwide, 3 million adults, and 470,000 children. That is a lot.
It was a lot more prevalent than I realized.
About 30 to 40% of epilepsy is caused by a genetic predisposition. 150,000 is the number of new cases of epilepsy in the United States each year. And that's a lot too. Mm-hmm. 1/3 of people with epilepsy live with uncontrollable seizures because no available treatment works for them. 6 out of 10 patients do not know why they have epilepsy.
So we're going to kind of go into the different type of seizures that you have when you have epilepsy. The first type is called a general seizure. It affects both sides of the brain. To generalize it, it's kind of how I think of it, so that it affects both sides of the brain. Absent seizures or petit mal seizures can cause like rapid blinking, or you can just kind of stare off into space for just a few seconds. It doesn't really last a long time. There are tonic-clonic seizures. This is also part of the generalized seizures group. These are called the grand mal seizures. These are the ones where when you think of seizures and what people, with their convulses, this is what this typically looks like. Patients can cry out, lose consciousness, fall to the ground, have muscle jerks or spasms, and then afterwards, patients are very tired.
Well, look at all the activity,
right?
Bodily activity that goes into that. I think anybody who has these tonic-clonic seizures would be tired.
Right. Oh, absolutely. The next category are focal seizures, and these are seizures that just affect one area of the brain. They also can be called partial seizures. And simple focal seizures affect a small part of the brain and can cause like twitching or just like strange sensations like smells or tastes to happen. There are complex focal seizures, and that can make a patient confused or dazed. They'll be unable to respond to questions or take directions while the seizure is happening, which is typically just for a few minutes. Secondary generalized seizures begin in one part of the brain and then they spread to both sides. So it's pretty much a focal seizure and then a general seizure, which is kind of rough.
Yeah, it's both of them.
And seizures can last as long as a few minutes. So they can be very quick, just a
couple of seconds,
2 minutes. So they don't last for what I would consider a long period of time, but that's a long period of time if you've ever seen anybody have a seizure.
Or you're the one that's going through it. Absolutely. Right. So some diagnostics in order to, make that differential diagnosis for epilepsy. Medical providers will conduct a medical review, and they will and should always obtain a medical history. They usually perform a neurological exam, so they're going to test your behavior, your motor abilities, and your mental function. They'll do lab work and blood tests to check it for any signs of infection, genetic conditions, or any other conditions that may be associated with seizures. They will complete an EEG, an electroencephalogram, and this is where they put the electrodes and attach them to your scalp with a paste-like substance.
Mm-hmm.
And the electrodes record the electricity activity that's in your brain. Your doctor may monitor you on a video when they're doing this test while you're awake or asleep to record any seizures you may experience. You may also have an ambulatory EEG, which means that you can wear it at home and it records any seizures or activities over a course of a few days. There's a high density EEG. It spaces electrodes more closely than conventional EEGs, about a half a centimeter apart, and that will help your doctor be more precise and determine which areas of the brain are affected by the seizures. Then you have your imaging tests, right?
Yep.
You have your CTs, your MRI, your PET, your SPECT, which I'm not really familiar with that one, so I had to look it up.
I was not familiar with that either, but I've never been a nurse to work anywhere near neurology.
It's interesting, really. So a SPECT test uses a small amount of low-dose radioactive material that's injected into a vein to create a detailed 3D map of the blood flow activity in your brain while you're having a seizure. That's definitely a lot more detailed. I would really be interested in seeing what one looks like.
I was just thinking that.
How
awesome would that be to sit
in
there
3D?
And watch? Yeah.
Yeah, I'm such a nerd. I'm over it. So neuropsychological tests. So in these tests, doctors are assessing your thinking, your memory, and your speech skills. And then there's a combination of analytical techniques to help pinpoint where the brain seizures start. And that's called a statistical parametric mapping. And in this method, it's comparing areas of the brain that have increased metabolism during seizures compared to that of, normal brains.
Right.
There's also a Curie analysis, which takes an EEG data and projects it onto an MRI of the brain to show doctors where your seizures are occurring. And then there's an MEG, which I also had to look up because I'm so not familiar with it. And it measures the magnetic field produced by brain activity to identify potential areas of seizure onset. So there's definitely a lot of diagnostic tools to kind of help, make the diagnosis of epilepsy.
Right. I know there is a lot that goes into it. When I was in high school, there was a girl there that I knew she has epilepsy. Mm-hmm. And they put her on medication, which really controlled it well. But because of the way she presented, they said that the medicine would get to a point to where it didn't work. Mm-hmm. She would start having seizures again, and then they would have to make some changes. Yeah. But they couldn't do it preventatively because you just didn't want to make alterations to a medication. You don't know if it's going to last for 2 years or 10 years.
Exactly.
But it was very embarrassing for her, especially when she would seize at school.
I can't imagine. I really can't. My nephew suffers from seizures, but his are the petite kind, mm-hmm. kind of stare off into space is, how they describe it. And that's how my sister-in-law, my brother, described his seizures. And he doesn't have them very frequently or often at all, but he has had them enough to where he's been diagnosed. And, those are a lot more mild. People are probably just thinking he's daydreaming or,
right.
That he's not paying attention. But I can't imagine having, like a grand mal or a tonic-clonic,
right.
seizure. I couldn't imagine. It has to be the scariest thing ever to witness and to go through.
Right.
I remember in nursing school, they said that sometimes patients can kind of feel mm-hmm. when they might have one coming on. And then I remember also, reading about service dogs or mm-hmm. medical dogs that are trained. Animals are trained for diabetics so that they can tell when they're... I know, it's so interesting. They can tell when their blood sugar is too high or mm-hmm. when their blood sugar is too low. And then, the dog really helps to tell that patient, okay, something's not right. Like check your blood sugar.
Yeah.
But I hear dogs can do this with epileptic patients as well. Like I want to say an aura. I think that's what it's called, aura.
Like you have with migraines, same
Yes,
concept.
like
Right.
I think I read, and I'm pretty sure about it, that these help dogs, service dogs, can sense that and can
That's
sense
amazing.
when one's about to happen, and then tell the patient, okay, you need to sit down. You know what I mean? Like something's getting ready to happen. Please have a seat. And I think it's amazing too. I'm so interested in just that aspect of it alone. I think that's awesome that treatment and help is available for people to have a service dog. That's
We should do an
specifically-
episode on service dogs.
Yeah,
and
there's
what
so
they
much
can
they
do.
can do. Yeah. We'll put a pin on that one and come back to it later.
It'll be a whole different rabbit hole, and this whole
I know.
podcast will be no longer about epilepsy.
You see what happens? We get to talking about epilepsy, and then we're on like this totally.
Service
Yeah, we're
dogs.
like, that's going to be episode 102.
So I'm going to go into a little bit of the treatments for epilepsy. So there's a lot of different types of epilepsy.
Mm-hmm.
And so that was not something that I was going to list or go through.
That's a lot.
And, you know, just as a little caveat, most of them I could not pronounce. So there's a lot of different types of epilepsy.
Mm-hmm.
Of course, when we say treatments, this is going to be kind of vague, but, you know, there are anti-epileptic medications, and some of those you have to take a combination of different types of medicine to help with your seizures. And some adults can even stop or come down off their medications if they don't have seizures for a certain amount of time. So really, the medications that you're on are going to be dependent upon your response to them, and how long or how much you're on is all going to depend upon how active your epilepsy is.
That's definitely individualized.
Well, it really made me think a lot about like similar treatment kind of with depression. You know, there are a plethora of different antidepressants, and the same two aren't going to work for you that work for me. And so it is a very individualized plan that comes together, and doses can be altered to help that one person.
Yeah.
There are surgeries where you can have for like a focal seizure kind of patients where they know exactly where the seizures are coming from, where you can remove the area of the brain that's causing the seizures. And doctors usually perform surgery when they know it's at like a small spot where it originates, that's kind of in an area of your brain that they can get to very easily, and that it doesn't interfere with, you know, any other function. You know, it can't interfere with your speech and your language and your motor function, vision, hearing, you know.
Well, yeah, the goal is to lessen the amount of seizures or not to have any at all. It shouldn't be the goal to stop the seizures and then have 101 other problems, you know, like
Right.
You're doing more harm than good at that point.
Although many people continue to need medications to prevent their seizures after surgery, it may be that you don't need as many. I would only want to do surgery if the seizures were very, very frequently and interfering with my daily life and the medication wasn't helping. And I'm pretty sure that that's probably
I think that's the goal.
the goal.
Standard.
You know,
Yeah.
I don't think that it would be, oh, I have a seizure once a year and I want to have this brain surgery to have this area removed. That really wouldn't be very effective.
I don't think that would even be ethical.
Right.
Like, how do you go from the least to the most dramatic? You know
Right.
what I'm saying?
Right. Because there are complications. You know, it can alter your cognitive ability. So you really need to do your research before you let somebody work on your brain.
Oh my goodness. And yes, ask questions.
Yes.
Don't ever stop. Just write them down with you, take them to your appointments, and you ask until you get, you know, the answer. Because, I mean, brain surgery is brain surgery.
And I think a good question to ask, because sometimes we just don't know what we need to know, if that makes sense. We don't really know what we need to know. I will ask, well, is there anything that I should be asking? Is there something that I should know that I haven't thought to ask you about? What would you ask if this was your family member? What would you tell somebody to ask if they were me? Like if I was your wife, or if I was your, you know, spouse or your sister, and you couldn't be with me to go to the appointment, what would you say? Make sure you ask da 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 da.
That's awesome.
Like-
Yeah, I'm in total agreement.
And a lot of them will actually pause and think about that because you really want what's best for your patient, and you want to be that advocate.
Absolutely. And, you know, we're so for patients being their best advocate.
Yes.
Absolutely. Like 100%. So there are other therapies that we can include with medications and all of the things that we've talked about. One is vagus nerve stimulation, where the doctor implants a device called a vagus nerve stimulator underneath the skin of your chest. It's similar to a pacemaker, and the wires from the stimulator are connected to the vagus nerve in your neck. There's also the ketogenic diet. And some children with epilepsy have been able to reduce the amount of their seizures by following a strict diet that's high in fats and low in carbohydrates. But like with any diet and changes that you're going to make, especially to that of a child, you definitely have to communicate and make sure that you're making these changes in accordance to your physician's recommendations. Like don't take this piece of information, a ketogenic diet, and then be like, I'm going to try that tomorrow. No one should ever do that as an adult.
No.
Let alone as with their children.
Right. And I think some people are, a diet that's high in fat and
it might not necessarily
and
be
low
the best.
in carbs. Well, it's the type of fat too that you're consuming that matters. So it's really good to you need to have a really well-rounded understanding. You know, the fat from red meat and the fat from an avocado are
Two
different.
Totally different things.
Yes.
Two totally different things.
That I think is a disconnect with that keto diet. Yep.
And I definitely feel like if this is something that your physician has decided for you or your child, that chances are they're probably going to get you connected to a nutritionist, in which they should.
Absolutely.
Deep brain stimulation, where surgeons implant electrodes into a specific part of your brain, typically your thalamus. The electrodes are connected to a generator implanted in your chest or in your skull that sends electrical pulses to your brain and may reduce your seizures. That is very interesting. I would like to see that.
It is very interesting. And it's funny in future episodes.
Yeah, I know. We're
You'll
working
see our
on
rabbit hole.
something. This happens every time.
It
We're
really
working
does.
on something special for you guys. Oh, it makes me laugh. We keep doing this.
So we did a little bit of research, and I found an article that I found to be very interesting. And I was like, really? Of course. Women always get the short end of the stick. The thought process of this was that so many people don't understand or know why they have epilepsy. You know, we gave a list earlier in the episode of different reasons why you may have it, but maybe you're in a category where none of that stuff's come back positive. You had the genetic testing. You don't have any abnormalities that are known to us at this time. I think that holds sometimes people can't find closure because of that.
Well, yeah, you're continuously searching for something for the need. You need to know what's wrong.
Absolutely. But while I was looking at that information, I came across another article, and it's about seizures during menstrual cycles, which is awful. So they're
awful to start with.
Exactly. That's why I said the women get the short end of the stick. It was an article from Science Daily, and in a nutshell, it explained that women who have a form of genetic epilepsy, that their seizure frequency increases during their menstrual cycle. And women were almost 4 times more likely to have drug-resistant epilepsy than women who experience no change in frequency during their menstruation.
Wow.
And so I was like, wow, your chances of having a seizure is 4 times higher because you're on your period. And if that happens, you're at the low end of the totem pole to actually have medication that helps control your seizures because you have this drug-resistant type of epilepsy. That's awful.
I think it is awful. I wonder if it has anything to do with the hormonal changes that people go through when they're on their cycle.
Maybe. Genetic generalized epilepsy is thought to respond better to anti-seizure medications versus focal epilepsy. However, there were previous studies that suggest a minority of individuals, and we're looking at 18 to 36% with genetic generalized epilepsy, do not respond well to those medications. So it really made me see we don't know much about epilepsy.
Well, I mean, the brain's a difficult
It
muscle,
really is.
let me tell you. They're still trying to figure things out.
It really are. And of course, at the end of the article, the whole idea was we need more studies done on a larger number of patients to learn more about this specific population.
Mm-hmm.
The thought process is if you can understand why this subgroup does not respond well to treatment
Mm-hmm.
and find out what they do respond to, then you may get new treatment options and better treatment options than are out there now, just by focusing on this one group. And it may kind of get back a little bit more to the core of epilepsy that we don't know about.
Mm-hmm. I agree. I think we need to, just in science as general, instead of always trying to, replicate things to the exact outcome each and every time. Because,
Right.
I mean, I do believe in the scientific method.
Right.
But I think because of that, when we don't really look at the anomalies, I feel like there's so much in those anomalies. Like, we need to figure out why that happened. And if we spent a lot of time researching anomalies, that we would have a better understanding of a lot of things, not just epilepsy.
Right. And that's the exact thought process here is research this little subgroup to find out more information. Because if you find one thing that's true and that, it may not fix this subgroup, say it gives them a 50%, 50% better control of their epilepsy. Great. But what if that took the people who did have pretty good control and were responsive to anti-epileptic medications? What if they didn't have a seizure again?
Yeah, it makes
because
a
they're
difference.
on this medicine. That is hundreds of thousands of people who could be, positively affected by a study like this.
I'm in total agreement. So another research that we've done, and I think is probably one of your favorite. I don't know. I feel like I should let you go ahead and do it. Because I know you're super stoked about it.
I am a little, and I'll be happy. There's a responsive neurostimulation. So this, Rosa's making fun of me because she knows I'm getting my nerd on right now, and that's completely okay. But it's the implantable pacemaker-like device to help prevent seizures. It is still under investigation. It's a responsive stimulation, or like a closed loop device, and it analyzes the brain activity so we can detect where the seizures are before it happens. And then what would happen is it would deliver, I say, like a shock or a charge or, a zap to that area to stop the seizure from happening.
I mean, that's interesting. The research is interesting.
It really is. There's another part of that, which is a continuous stimulation of the seizure area.
Well, I'm interested in all of it, and I'm sure you're going to hear a lot about it. This particular treatment option that's being researched
Yes.
a few episodes down the line.
Yes.
Because it's the nerd in us and we can't help it. No shame. But these treatment approaches, they may work in people who have seizures that start in an area of the brain that can't be removed because it would affect speech and motor functions. So it's an alternative.
Yes.
Because like we said, it's medication at this point or surgery.
Yeah. So to have something that can be implanted, given even something that's implanted like this, that's stimulating your brain, you still need to, there's a lot of questions to be asked. There's still a lot of research that needs to be done. But you're talking about, having something send an electrical charge to an area of your brain to alter what your brain function is about to do.
Yeah.
It's just crazy to me. It really
science is amazing.
It blows my mind.
Yeah, literally.
Yes.
So there are other types and other researches as well, like minimally invasive surgery. And this new minimally invasive surgery technique is MRI guided laser ablation, and it shows promise at reducing seizures with fewer risks than traditional open brain surgery for epilepsy. And I believe that, and everybody knows anytime that you break that surface of the skin that you're you're now exposed to a lot more things that you might have not been exposed to before. Infections, just the brain is so unpredictable to begin with. So if you have something that's minimally invasive, that's a big step forward, period.
Mm-hmm. Oh, absolutely. That's always the goal, is to do something minimally invasive.
Exactly. I just feel uncomfortable with the thought of my brain being open.
Depends on who's opening it.
So another one is stereotactic laser ablation or stereotactic radiosurgery. In these procedures, the doctor is directing radiation at a specific area in the brain that causes the seizures. And it's to destroy that tissue that's causing the seizures in an effort to better control the seizures.
Yeah.
The external nerve stimulation device is similar to the vagus nerve stimulation device, but in this device, it would stimulate a specific nerve or nerves to reduce frequency of seizures. But unlike the vagus nerve stimulation, this device would be worn externally so that there is no surgery to implant the device. That's a pretty good option too.
Well, I would pick that over one that needs to be implanted at least first.
Even just as a trial period, because if it works well, then maybe you're willing to take the next step.
Right.
So that's good.
One of the things as nurses, we need to make sure that we're educating patients, family members on just the basic, first aid and safety considerations for their family members.
Absolutely.
It's sometimes when you see somebody, especially if you've never seen a seizure before, the first time you see it, it's very especially a big seizure, like a grand mal.
Mm-hmm.
It's scary. So when you know what to expect, it becomes, I hate to say routine, but you kind of develop a pattern.
Your response to it will be more effective.
Right.
Then, yeah, I can see that.
So one of the things that you can do is stay with a person, and you want to make sure that you stay calm. If you get in a situation where you're panicked, it's not helping anything. You can check, if you don't know the person, for a medical ID. If you see somebody that just falls out, that's a good tip for anybody that just falls over. Yeah. And you want to make sure that if there's somebody else with you, that you stay with the person, but you call for help. You want to call, 911, something.
And these are your basic life-saving skills,
They really are. And if a patient or a person is having a seizure, you just want to make sure that they're not going to injure themselves on anything that's around them. So you just want to move stuff to make it a safe place.
So you definitely want to keep yourself safe first. That's definitely basic life-saving 101, is to always make sure you're safe. But you want to keep the person who's having the seizure safe as well. Mm-hmm. So you want to move or guide them away from any sharp or harmful objects. And if the person is wandering or confused, just help steer them, clear them away from any objects that might hurt them. Mm-hmm. For instance, if they're getting ready to walk into traffic, you or anywhere actually, just kind of guide them back to a safe place. Encourage people to step back and, give the person some room. Waking up to a crowd can be embarrassing, and it's super confusing for the person that's having the seizure, because I think most times they don't remember anything that happens with their seizures at all. So you can imagine this person having a seizure that lasts a couple of minutes, and then they wake up and they see a bunch of faces. That would freak me out.
Yeah.
That would super freak me out. So you definitely want to ask someone to stay nearby in case you need more help.
Well, absolutely.
You want to make sure that you turn the person on the side if they are not awake or even aware that they're having a seizure. You want to make the person as comfortable as possible. Loosen tight clothing around the neck. If they are aware help them sit down in a safe place. And if they are at risk at falling or having a convulsive seizure or a tonic-clonic seizure, lay them down on the floor and put something soft and small under their head. Turn them on their side with their mouth pointing toward the ground. This prevents saliva from backing into their airways and helps the patient to breathe more easily. And during, the seizure, it may look like the person has stopped breathing. This happens when the chest muscles tighten during that tonic phase. Mm-hmm. And as this part of the seizure ends, the muscles will relax and breathing will resume normally.
There are a couple of things that you want to make sure that you don't do with a person or a patient that's having a seizure. Some of this may seem like, well, of course, but we're telling you this because
it's been done before.
It's been done before. Absolutely. Do not put anything in the person's mouth. They are not going to swallow their tongue. Just no.
I can't even picture that.
It's something that people hear a lot. They're going to swallow their tongue. No, they're not. It's attached. So it's not going to go anywhere. The jaw and the face muscles will tighten, and the patient will bite down and clench down. And if there's something that's in their mouth preventing that, then they can break their teeth. It'll actually do them more harm than good. So just don't put anything in their mouth.
Well, and remember that, like, remember in CPR 101, they used to tell you to finger sweep.
Yeah.
This is the reason why they tell you not to do that anymore.
Right.
Because of this right here. When they clench down,
you break your finger.
They're going to get your fingers in there.
Yep. Of course, there are rescue medicines that can be placed inside the cheek, but that's usually given by like a healthcare professional or somebody that's been trained to do so. Do not give them water or food. They cannot swallow a pill. If there's medicine that goes in their cheek, it dissolves in their mouth. Mm-hmm. That's how it's absorbed and how it works. So it's not the same of, let
me give you a pill.
Let me give you your anti-epileptic medicine that you forgot this. No, that doesn't work. Another thing you do not want to do is to try to hold somebody down while they're having a seizure. That's not gonna work. And you're gonna get hurt.
Well, both of you are.
Like Rosa said earlier, you want to make a safe spot. So like if there's a chair that somebody's going to hit their head on, move the chair. Don't let them do their thing, but move the chair out of their way so they don't hurt themselves.
After the seizure is done, remember it only takes a few minutes. So right. They're not long. And, sometimes injury can occur during or even after a seizure. So sometimes, they're going to need some help. And if a person appears to be choking, you just want to make sure that you turn them on their side and that you're calling for help. If they are not able to cough or clear their air passages on their own or are having problems breathing, you're going to want to call 911 and, be sensitive and supportive and, ask others to do the same. It's severe and you need immediate attention and need to call 911 when the seizure lasts over 5 minutes. They're having repeated seizures, one after another, because I can tell you something's not right.
No.
They have difficulty breathing. The seizure occurs in water. The person's injured, pregnant, or sick. If the person does not return to their usual state. And if it's their first seizure, the person and of course, if a person's asking for you to do so, like call
right.
911, something's not right. Because like I said before, some people
have the
ability or that feeling, that aura of, okay, I'm about to have a seizure. So you just want to make sure that those are the reasons, that you're calling 911 and you always want to stay with, the person having the seizure.
Right.
As always, we will link our references to our website, www.thenursingpostpodcast.com. We would love for you to join the conversation by leaving comments and suggestions there too. And be sure to subscribe to our podcast. We're on all the platforms and on all social media. So thank you again for listening.